My name's Ed Howard. I'm with the Alliance for Health Reform, and on behalf of Senator Rockefeller, Senator Blunt, and our board of directors, I want to welcome you to this program today on the large and growing problem of painkiller abuse, specifically opioid abuse in America today. Not only are there thousands of deaths each year from these abuses, but the illicit demand for the opioids has created problems for healthcare providers, for drug suppliers, law enforcement, anybody paying for prescription drugs. At the same time, you got countless individuals who are in severe pain, sometimes at levels that these powerful drugs can relieve, and efforts to control their abuse have to be balanced by the real needs of these patients. So today we're going to take a look at the extent of the problem and at some of the many efforts to cope with it by individuals and the institutions that are affected by it. We're very pleased to have as our partner in today's program the Pharmaceutical Care Management Association, PCMA, whose members aim to enhance the value of pharmacy dollars that are spent by employers, health plans, other players, in benefit arrangements covering something like 2/3 of America's population. And joining me in moderating today's discussion is the head of PCMA, the CEO, Mark Merritt. Mark?
Thanks, Ed. I appreciate that. And thanks all of you for coming this early. I'm trying to think if I would be here if I wasn't actually speaking. But thanks so much. This is a great forum. It's one of the few remaining forums in town where I think real business gets done in healthcare, where there's real discussion, real debate, and I appreciate you, Ed, hosting this. And also thanks to Senator Rockefeller and Blunt and others who are involved in the Alliance. And I think this issue, is unique because in Washington, we've been conditioned to view healthcare as just another divisive issue, almost like a social issue, where in the end, nothing's going to get done, or whatever does get done is going to be so filled with politics that it's, doesn't accomplish all the things you hoped it would. And this is a real issue, though. This isn't a political health care issue. This is a real issue. And not just because it's an epidemic that's cost 20,000 people a year their lives, but it really touches every part of health care, from cost, waste, fraud, and abuse, health, again, increasing illicit demand for these products, the role of providers, and so forth. And if there's a silver lining to this policy, it's that it's one of the policies that you really can solve with a good policy solution and without all the political landmines that destroy so many other good ideas. It's bipartisan. There are bipartisan solutions to this. It's a solution where it's provider-centric. Providers, in this case pharmacists, and particularly from our view, have a role here. It saves money, doesn't cost money. So you don't need more money. You don't need to revamp the healthcare system. You just need to modernize and tweak things just a bit. And as the Office of the Inspector General at HHS recently said, really the solution is to have patients choose a pharmacy where they get painkillers and other drugs that are subject to abuse, diversion, and so forth, and monitor the supply, because these are prescription drugs we're talking about. This isn't Breaking Bad and meth labs and RVs. These are prescription drugs where the supply chain is very solid. And if you can just keep them from crossing the pharmacy counter into the wrong hands, you win. And so that's really what we need to do. We're focused on that. We're thankful to folks like Congressman Kevin Brady and Frank Pallone and Gus Bilrakis, Ben Ray Lujan, and others who have led the way on this, particularly on the safe pharmacy idea, the idea of patients having one pharmacy, maybe two, if they're snowbirds, where they get these products, so you can make sure that they're not drugstore shopping, not getting one script, real or falsified, and sending it to 20 pharmacies in a given day where community drugstores don't talk to each other. We need to fix that and get this out of the dark ages using the health IT and the other tools that we have available. So I'm going to stop there. I'm really interested in what these folks have to say. I'm looking forward to hearing from them.
Terrific. Thank you very much, Mark. And I should add to your list somebody who's very interested in this is Senator Rockefeller. And you'll be hearing more about West Virginia later on in the program. But it's obviously a problem in his jurisdiction. A couple of quick notes. You see the Twitter hashtag opioid abuse, if you want to use that, and instructions on how to get Wi-Fi, if you need to have Wi-Fi to tweet, are on each of your tables. There's a lot of background information in your packets, including biographical information on our speakers. And there'll be a video recording of this event probably on Monday on our website, allhealth.org. A couple of days later, we'll have a transcript on the same website, along with electronic copies of all of the materials that you see in your packets. You can ask our panel a question at the appropriate time. There are microphones you can use to ask your question orally. There are green question cards in your packets that you can write a question on, and it will be brought forward. And then a blue evaluation form, which I hope you will use as we go along to keep score and to tell us anything that you'd like to tell us about the quality of programs, what topics and speakers you'd like to hear in the future, and try to improve these briefings for your use. I think that's all of the overhead announcements. Let's get to the panel. As Mark alluded to, we have quite a stellar lineup for you today. And we're going to start with Grant Baldwin. Grant is from the Centers for Disease Control and Prevention, CDC, where he directs the Center of Unintentional Injury Prevention, which is part of the National Center for Injury Prevention and Control. And one of his principal areas of responsibility is the center's prescription drug overdose prevention efforts. And we've asked Dr. Baldwin to give us a sense of the breadth of the issues involved in overdose prevention, and particularly from a public health perspective. Grant, thanks very much for joining us.
Thanks a lot, Ed, and thank you, Mark, for inviting me as well. Good morning. It's certainly a pleasure to be here today.
We only have 6 minutes left.
Yeah, I was going to say, my time is cut short. My role is to talk about the burden and who's at risk for a prescription drug overdose, and I'll also discuss CDC's public health approach to prevention. CDC really has played an important role in sounding the alarm, raising the visibility of the health impact of prescription drug overdoses, and working to better understand the causes of the epidemic. This includes the increase in the prescribing of opioids in the treatment of chronic non-cancer pain, where their utility for long-term pain relief is uneven, and the risks may in fact outweigh the benefits. This gathering today is another marker of the groundswell of large-scale bipartisan and multi-sector support and commitment to address this epidemic. So if a picture is worth 1,000 words, then these pictures are worth 125,000. That is the number of prescription drug-related deaths in the last decade. This time series map shows state-based drug overdose mortality rates shifting between 1999 and 2010. Prescription drug overdoses are among the few causes of death that are on the rise, and the trends, as you see on the slides, are pretty stark. Similar to how state-based obesity maps in the last 30 years poignantly highlighted the bulging waistlines of Americans, these drug overdose maps show the epidemic taking hold across the country. Every state has seen dramatic increases in mortality rates, with some states in Appalachia and the South being among the hardest hit. As most of you know, opioid pain relievers such as OxyContin and Vicodin are responsible for driving the dramatic increase in overdose deaths in the last decade. The purple line is the one to follow on this slide. The trajectory and rate of increase for opioid analgesics is much different than that from other drugs between 1999 and 2010, and you can readily see the fourfold increase in deaths. The number of deaths from opioids far outnumber those from heroin and cocaine, and in 2011, nearly 17,000 people died from a prescription opioid overdose, or about one death in every 30 minutes. I also flagged the recent sharp growth in heroin overdose deaths, a phenomenon not unrelated to the opioid overdose epidemic, and I'll discuss that more later in my presentation. One driver of the increase in opioid overdose deaths is an abundance of supply of these very powerful drugs. This graph shows the relationship between the sales of opioids, the green line, and the number of deaths from them, the blue line. As you can see, as the amount of opioids sold increased, so too did the number of deaths. The supply of opioid pain relievers is larger than ever. The quantity sold in 2011 was 4 times that sold in 1999. The red line shows that substance abuse treatment admissions for opioids increased dramatically as well during that same time period. And by the way, opioid-related overdose cost an estimated $20 billion in medical and work loss costs annually. At the core, the prescription drug overdose epidemic is a prescribing problem. Healthcare providers wrote more than 259 million prescriptions for opioid painkillers in 2012, with wide variation across states. Healthcare providers in the highest prescribing state, Alabama, wrote almost 3 times as many prescriptions per person as those in the lowest prescribing state, Hawaii. Most of the highest prescribing states were in the South. Earlier studies suggest that regional variation in the use of prescriptions cannot be explained by the underlying health status of the population. As CDC Director Dr. Tom Frieden said recently, sometimes the treatment becomes the problem. To reverse this epidemic, we need to improve the way we treat pain. Rates of opioid use and overdose death are highest among men, people in their working years of life, and non-Hispanic whites. Poor and rural populations in general are more likely to experience a prescription overdose as well. Finally, those at greatest risk are likely to have multiple prescriptions, are seeing multiple prescribers, and are on a high daily dose. These risk factors have important implications for prevention. As I mentioned earlier, heroin use and overdoses are increasing too. However, they remain far lower than opioid misuse and abuse. Though CDC's national mortality data only go through 2011, cities, counties, and states from across the country have reported recent increases in heroin overdoses. Later this week, CDC will release a study on heroin prescription opioid mortality in 28 states that will further examine these trends. Several things appear to be driving the increase in heroin overdoses, including widespread prescription opioid exposure and increases in rates of opioid addiction. An increase in the heroin supply and the cost of heroin relative to prescription drugs are also factors. More than 3 out of 4 people seeking treatment for heroin dependence were exposed to opioids before heroin, and more than 7 out of 10 people who reported past year heroin use in 2008 to 2010 reported using opioids non-medically in the past year. The relationship between prescription opioid abuse and heroin, frankly, is not that surprising. Heroin is an opioid, and both drugs act on the same receptors in the brain and produce similar effects. The connection between opioids and heroin misuse suggests that public health interventions addressing the opioid epidemic may help curb the heroin abuse and overdose problem. I was going to say, I'm just stockpiling microphones. Much of CDC's work addresses state-level interventions, and Alan will be talking about a couple of these in greater detail. States have access to the major levers that can reverse the epidemic. Specifically, states maintain prescription drug monitoring programs, or PDMPs, regulate healthcare professions, monitor the problem in their state health departments, and run large public insurance programs such as Medicaid. Prescription drug monitoring programs are state-run databases that track the dispensing and prescribing of controlled substances. Though virtually all states have an operational PDMP, these programs vary considerably between states in both their scope and their impact. Another linchpin intervention are patient review and restriction programs, or lock-in programs. These programs enable state Medicaid programs to rein in Medicaid patient overuse and possible abuse of physician services and prescription drugs without having to terminate Medicaid benefits altogether. They do this by restricting patients suspected of overutilization to a single designated provider, pharmacy, or both. Success is possible, and recent accomplishments in Florida are a testament to the opportunities before us. Prior to 2010, Florida had a major problem with prescription drugs, and between 2003 and 2009, Florida saw an 84% increase in prescription drug overdoses, with 8 people dying every day. Pill mills were rampant. Beginning in 2010, Florida legislators took action, tightening controls on pain clinics and how they were regulated. The DEA and the Florida law enforcement officials worked together on Operation Pill Nation, and other actions followed. Florida saw huge decreases in opioid prescribing and overdoses, especially with oxycodone. Opioid overdoses dropped by 27%, and oxycodone overdoses dropped by a staggering 52%. So while it is an earlier marker, it spotlights the promise and possibility. CDC is focused on improving data quality and the use of data to monitor trends and the causes of the epidemic, strengthening state public health capacity, and improving patient safety by supporting healthcare providers and systems. One of our signature initiatives is a $6 million program known as Prevention Boost. Began in 2014, it equips states with the resources they need to prevent prescription drug overdoses. And our goal is to advance prevention in 3 key areas: maximizing prescription drug monitoring programs, improving public insurance mechanisms to protect patients, and evaluating policies to identify prevention strategies that work. The 5 Prevention Boost states, Kentucky, Oklahoma, Tennessee, Utah, and West Virginia, are among the states with the highest drug overdose burden in the U.S. and have demonstrated the readiness and collaborative approach needed to make immediate progress on the epidemic. There's a proposed $15.6 million increase for CDC's state-level prevention work in fiscal year 15, and CDC hopes to leverage these resources to expand and maximize our state-level efforts. So with that, I'm out of time, and let me turn it over to Alan from Pew.
Alan, let me just let people know how important it is that they listen carefully to what you are going to say. Alan is, as Grant said, from Pew Charitable Trusts. He's the Senior Director for Drugs and Medical Devices and oversees a whole range of initiatives, including one on prescription drug abuse. He's a pharmacist by profession. And Alan's going to tell us about some of the policy initiatives already in place to deal with overdoses, including those state-based drug monitoring programs that you've heard from Grant about. Alan, thank you very much for being with us.
Well, thank you, and I'd like to thank the Alliance for Health Reform and PCMA for the opportunity to be here today. Pew is a nonprofit, nonpartisan research and policy organization, and as Ed has said, this is one of the areas that we're focused on. It's an important area. So I'm going to quickly talk a little bit more about prescription drug monitoring programs, which Grant touched on. The federal policy landscape, really I'm going to focus on patient review and restriction programs, and then if there's time I want to talk about one other drug that I think is particularly important. So Grant's done a great job of giving us the sort of epidemiology of the drug abuse crisis. It's absolutely a fraud and abuse problem, but it's also a public health problem, and it's also a problem of chronic disease management. I put up the cover of the IOM report on pain control to remind us of that. 100 million Americans have chronic pain. A lot of them, as Grant has said, are getting opioids, not all of them appropriately. But as we think about this population, we've got to make sure that we're not just cutting off the supply. A big part of dealing with this has got to be getting people into some kind of coordinated, effective pain control. And I think that's an important thing to keep in mind as we go through. One big part of this that I won't talk about today, though, is medical practice, making sure that physicians are equipped to deliver effective pain control. So prescription drug monitoring programs, this is a report that we commissioned in 2011. Prescription drug monitoring programs are state databases that collect all controlled substances scripts. They vary, as Grant has said, a lot from state to state. The field is changing so fast that a lot of what's in our 2011 report is no longer relevant. We're going to update it, and I've borrowed some slides with more recent data. But here's a quick schematic. So the pharmacy has fills prescriptions. They update that into a database. The clinical user, the physician, logs on to the database to see if their patient's getting scripts filled elsewhere. This is the big weakness. We can build the database, but if the doc doesn't log on and check it, they won't work. And if it's an extra step and an extra log on, that's just not going to happen. So utilization is a big problem. One thing we can do is send proactive reports out to the doc, so we're not waiting for someone to go and check a database. Another important thing is integration with the EHR, and SAMHSA and the Office of the National Coordinator for Health IT are funding some good work to drive that integration into the EHR. Something that's, I think, relatively new but promising is using the existing architecture of health information exchanges to get PDMP data into the EHR. And at least one state has actually made that declared it a public health database, which means that hospitals can receive meaningful use credit for integrating the PDMP. And then the other thing, so public health and law enforcement are also accessing, and then data exchange between other states. So a number of organizations have deep knowledge of PDMPs. I've borrowed some slides here from the Training and Technical Assistance Center, which is funded by the Department of Justice and sits at Brandeis University. So here we are, the landscape in 2014. Every state except Missouri now has enacting legislation for PDMPs. Most of them are operational. This is how often the pharmacy data goes in. So about half of the states are doing it weekly, 17 states are doing it daily, one state, Oklahoma, is updating in real time. The relevance of that, of course, is if the data is a month behind and you're going to the PDMP to see if the patient's also getting scripts filled somewhere else, you're not gonna know. This is 2012 data. This is unsolicited reports, so the proactive reporting to the doc that I mentioned, so you see some momentum there towards more of that, but still a lot of states not doing that. It's an important thing that to drive up that utilization, get it in front. This is an interesting trend, mandatory utilization. So this is requiring the docs to use it. Now, what this means varies a lot by state, but it is catching on. And in New York, for example, when they mandated utilization of the PDMP, queries to the database went from 11,000 a month to 1.5 million a month. Really remarkable. Here's delegate access, so it doesn't have to be the doc. Some mid-level healthcare practitioner in the office can check it. So another way to get that information in front of the prescriber. So there's delegate access in 2014. Interstate operability coming along nicely. And funding. So a fair number of states now have some dedicated funding. It doesn't mean they have adequate funding, and it certainly doesn't mean that Congress can relax about funding the Hal Rogers program, which has been crucial to building these databases, and the NASPR program, which has not been funded for a couple of years, but is another really important potential source of funding for PDMPs. So moving along, so a lot of agencies, and this certainly isn't all of them, are playing important roles here. I'm going to focus mostly on CMS and on PRR programs. So a PRR, patient review and restriction, also called lock-in, although I avoid that because I think it sounds pejorative and punitive. I think we have to brand it, but also think about it as a way to get people into coordinated care. People with chronic pain, if they're seeing 10 doctors, they're not getting good care. So most state Medicaid programs have a PRR. They vary widely in what they're doing. Many of them are on the books and not terribly active. Here's Washington State as an example, and this comes from a recent paper in the Journal of Managed Care Pharmacy, which is, I think, the best published analysis of what exists in Medicaid lock-in programs. So here's Washington, somewhat typical. So if a patient within a 3-month period meets any of the following criteria, more than 4 or more prescribers, 4 or more pharmacies, 10 or more prescriptions with 2 or more prescribers in a month, the plan says you need to commit to 1 pharmacy and/or 1 physician in order to keep getting reimbursement. One of the weaknesses, of course, is if somebody's really bent on avoiding detection, they can go outside, pay cash. They don't show up in the funders' records. If only there was a way to find cash prescriptions. Oh, there is, the prescription drug monitoring program, but it's important that that gets integrated into the lock-in. This is a busy slide. Key message. So Washington, about 7 years ago, did a randomized trial, not of their highest users, but of kind of mid-level people who were eligible for the lock-in. Good number of patients enrolled. Bottom line is costs fell in the PRR program, rose in the control arm. Emergency department costs down. Overall savings about $4,000 per person per year. No significant effect on health outcomes, but maybe that's not surprising given the duration of the study and the difficulty of connecting these things. But also, self-reported health status similar, so people also didn't seem to be harmed by the program. So here's characteristics of a lock-in run by a PRR. See, I can't follow my own advice. By Humana. Similar sort of eligibility criteria. A couple of good things about this plan. One is that it includes an offer of treatment, so it's not just restricting to pharmacy, but offering the patient access to treatment. There's review by a fairly healthy staff, so it's not just generated by an algorithm. There's some judgment involved. And it's important to say that this same plan could not operate this program in Medicare Part D because right now that's not allowed. So that's one of the things that we could fix to allow these same organizations to run these programs in Medicare Part D. Just quickly, on one drug. There's been a lot of focus recently on Zohydro and the need for abuse deterrent formulations and so on. One of the things that I think is really important that's flying under the radar is methadone. So the gray bar is methadone deaths. The bars on the left are other opioid stack deaths. So methadone, this is not methadone for heroin addiction. This is methadone used as a first line or as a treatment for chronic pain. It's a long-acting opioid. It accounts for 2% of opioid prescriptions and 30% of deaths. CDC and FDA, professional associations recommend against its use as a first-line therapy, and yet it remains on the preferred drug list in Medicaid in most states. So that's certainly something we could look at. So thank you.
That's terrific. If we can get you to pass the clicker down. Thank you. We're going to turn next to Joellen Abu-Nader from Express Scripts, where she's their Senior Director of Fraud, Waste, and Abuse Services, and that means she's preventing those things. Now, with billions of dollars at stake and the powerful pull of addiction at work, there's no getting around the incentives toward fraud and abuse. Now, for more than a dozen years, Joellen has been rooting out that fraud and abuse for Express Scripts, and she's here to share some of her experiences in that activity with us. Joellen, thank you.
Thank you very much. Can everybody hear me? All right,
Get pretty close.
there we go. All right, so Express Scripts is a pharmacy benefit manager, and we have a unique position in that we service today 1 in 3 Americans across the country. 1.4 billion scripts a year. It's quite a bit. With that, we have a lot of data analytics and mining capabilities, predictive analytics capabilities. But to give you a picture of how we fit in as a PBM, a patient will take a prescription into a retailer, and that prescription will then be adjudicated through the system to a pharmacy benefit manager. It'll bump up against edits, refill too soon edits, clinical edits. The patient will then get their prescription. Express Scripts will pay the pharmacy for their services, and then the payers will then pay Express Scripts. So that's how the process works. But with that, we have to service 3,500 clients across the country, and they are very concerned about this issue. They're very concerned from many different aspects. They're concerned from the stance of ER visits are going up. We're seeing a large number of short-day supplies of prescriptions coming out of ERs, but it's not just the prescriptions that are coming out of ERs, it's all the medical services associated, the x-rays, the CAT scans. The loss of productivity at work for the employers, the risk to their organization. You know, if they have somebody that's traveling down the highway as their job and they may be on these prescriptions, there's risk for their organizations. And they want safety for their members long-term and their family members. In addition, there's a fine line between crossing that fine line with fraud. And so we want to make sure that we're trying to get it early to prevent future behavior. As I said, the medical claims associated with them getting the prescriptions is a $1 to $41 multiplier. For every dollar on the prescription side, it's $41 on the medical side for them to doctor shop. And again, it's the x-rays and CAT scans and all the fees that are associated with them to get that sometimes generic Percocet script, which is very costly. So we take a comprehensive look. We're looking at all of the claims for a patient, regardless if they're within a specific state. They could cross multiple states. We have the ability to look outside of just the PDMPs view. And so yes, as Alan said, sure. So as Alan said, Missouri is the only state, and that's where Express Scripts resides. And we're seeing an increase of scripts coming into the state of Missouri from neighboring states such as Illinois, and we've done studies on that. So we're very aware. But as the PBM representing over 3,500 clients, we have the ability to look across all 50 states for their members. So we can look at the physicians and the pharmacies they're going to and look for trends across the United States. Again, we're looking at predictive models. How do we identify it earlier? How do we identify risk scores for not only the pharmacies, but the physicians and the members? based on their utilization and how they're practicing medicine. My team has clinical knowledge. I have pharmacists, I have pharmacy techs that have worked face-to-face with patients at retail, mail order, infusion, specialty, various areas. And I also have people from investigative backgrounds. So it takes a diverse team to work these types of cases. To give you a couple case studies, this was an actual case where it started out as a drug seeker, one individual drug seeker that was doctor shopping to multiple physicians. But as I said, we have a comprehensive approach. And we don't just look at one patient and their utilization. We're looking at the physicians they're going to, and is there an issue there? Or is it the pharmacy that they're going to, and are they linked to multiple other pharmacies, or are there owners that are involved? And so in this case, an individual drug seeker ended up being 5 cases involving 7 clients, 17 members. Half of them had their IDs stolen in this case. 19 prescribers, 80 pharmacies, 28 counties, and over 200 claims. Again, these are low-dollar drugs sometimes because they are generic, and that is what they want at times, is the generic hydrocodone. However, again, the multiplier on the medical claims is astronomical for these. The second is a case study. We call this patient Anne. So Anne was a doctor shopper. She went to 17 prescribers within a 14-month time frame, 43 prescriptions, and 5 pharmacies. She had over 2,800 unit doses of prescriptions in a year. And you might say, Joellen, how does she get such a thing through your adjudication edits? Well, the doctor shoppers are pretty slick, right? When they want their drugs, they try to circumvent our edits. And that's why we have the analytics we do to try to identify those early. But what happened is that Anne was going to multiple ERs. You can see the list in the pie chart to get the controlled substances, short day supplies, long and short-acting controlled substances, and many different types to circumvent the edits for refill too soon, max daily dose, etc. So what we did is we actually locked Anne into a restriction program that the payer had signed up for, that they wanted to get their members treatment, they wanted to get their employee treatment. And what happened is we sent the letter out to the patient restricting her to one physician and one pharmacy to get only her controlled substances. So the restriction program allows her to go get her antibiotics, any other types of drugs, but the controlled substances, she needed to go to one physician to get her pain therapy. And so with that, Anne actually signed up for an employee assistance program, and she's actually doing very well. She's restricted to still the one physician and one pharmacy, but her treatment is going very well, and we receive feedback from the clients. So these are the success factors with us being able to intervene earlier than later, so that there isn't a death associated long-term in these cases. Now again, there is a fraud side to these pictures, and sometimes it does cross over into fraud. And like I said, it's the collaboration with the clients that are very important with the payers. We want to make sure that we're intervening as early as possible to improve health outcomes for the patients, but we also want to make sure that if there is potential fraud or ID theft, that we're getting those early too and protecting those victims in ID theft. We're also looking at physicians and pharmacies. Are the physicians the ones that are actually attributing to the disease for these patients? And if so, we need to take action on them. From a pharmacy perspective, since we manage those contracts with the pharmacies, we have over 65,000 in our network across the country. We work these cases very closely because we want to make sure that they're servicing the patients as we expect them to from their contracts. And if they're not, we're going to take action on them as well. We work with government officials across the country, such as the medic with CMS, to make sure that we're targeting these pharmacies that are not behaving appropriately. From a member perspective, we want to make sure that we're either helping them early on to get case management or a restriction program or some type of case management through the health plans that they can assist them with their behavior. The last thing we want is for their benefits to be terminated because we want to make sure that they're getting help. So the three key takeaways that I want you to make sure that you have are that the PBMs, the pharmacy benefit managers, are uniquely positioned to not only identify, but to investigate these cases for fraud, waste, and abuse, and to collaborate with our payers. We want to make sure that there is a restriction program. We would love to see one in the Medicare world because our payers are really struggling. They're struggling because they do not have a way to control the behavior and the tools to be able to do that. So with that, I will turn it over to you, Ed.
Great, thanks very much, Joellen. Finally, we're going to hear from Dr. Sarah Chenard. She's the medical director at Community Care of West Virginia, a federally qualified health center serving a large part of that state. She's also involved in a whole bunch of state and national leadership roles in areas like rural health and information technology and public health, all of which are relevant to this conversation. Painkiller abuse isn't an abstract concept with Dr. Chenard. It's a problem she has to cope with every day. And today, she's going to let us get a look at some of the problems she and her colleagues at Community Care encounter and how they deal with them. Doctor?
Let's see, is that working? Yes, okay, great. Well, thanks for having me. I think I'm the boots on the ground perspective here. Everything that's been said so far is something that I think about on a daily basis as a rural health practitioner. I had some slides prepared. A lot of this has already been covered, and I'm gonna go through these quickly, but I did wanna show you two things. This is where we're located. So this is central West Virginia. We are nowhere near a large city. We have 50 healthcare providers working in these locations. 20 of those are doctors. The other 30 are mid-level practitioners, nurse practitioners, physician's assistants. And this clinic is a very typical site for us. This is one of our locations. So just picture yourselves going to your doctor's office, and this is your doctor's office. The people working in these offices are people like me, and the people showing up in these offices are showing up on things like this. This isn't a joke. This is 2 weeks ago. A patient came in to see one of my colleagues just drenched in sweat and apologized. He said his father-in-law needed the car that day and rode that bicycle 7 miles to get to the clinic. So I'm not over-dramatizing. I'm not trying to make it sound like it's something that it isn't. This is just exactly how things are where we're practicing. We have 30,000 patients that we're taking care of in our clinics. And so in those clinics, one of the things that happened, I've been there for 10 years, is this prescription drug abuse problem sort of crept up on us. And so originally, all of our family doctors, and these are people who went into family medicine because they really do want to treat the variety of illnesses that afflict all of the people who are in your families and see them in their own communities. None of these people went into medicine because they had an interest in treating chronic pain. I think importantly, none of these people are equipped, myself included, to treat chronic pain. Chronic pain is a specialty. I went through a rotation in surgery and they told me that I could take out an appendix. I would never do that in my office. I don't see chronic pain as much different from doing an appendectomy. It is a specialty. It requires special training. And the training that we get as family doctors now, after residency, is a mandatory 3 hours every 2 years. So if any of you would feel confident in my ability to treat your chronic pain, that would be silly. Yet the demand is there. And so one of the things that I think people outside of our communities think is realistic is, well, send them to a pain doctor or send them to a pain clinic. If you'll go back to that slide that was the picture of our office, I would ask where those are. Where are those pain clinics? Where are those places that we're supposed to send these individuals? Transportation is an issue. Money in general is an issue for these patients. And what we strive to do is allow people to keep care in their own communities. So one of the things that Alan said is he said we need to get people into coordinated, effective care. He also said that one of the weaknesses is the doctor's ability or interest in using these PDMPs. Well, one thing that's really happened simultaneously is Medicaid expansion. And Medicaid expansion has really increased the need for more primary care physicians in places like the place that I work. So one thing that's always been an issue for us is recruiting and retention. Again, if any of you would like to work in those communities, sign right up, but it is difficult to find people to come and work in rural West Virginia. Well, we, in our own state, have had this tremendous ability to both recruit and retain primary care physicians, and the dirty little secret is not because we're so great at what we do, it's because we have a way to allow family physicians to wipe their hands clean of having to treat chronic pain. And we developed a program that's really innovative and that I think is something that if we could figure out how to spread nationally could really help do two things: lessen the burden on family docs who typically don't want to do this anyway, and also improve the care that people can get. If I were in your shoes, I would be asking myself, why do the doctors write all these drugs? You know, why are there so many pills? I mean, that's something that people in my family ask me. You know, ultimately, don't all these drugs come from you? I mean, not all of them, but lots of them do. And I think the answer is twofold. It's a lot easier to write a script and end the conversation than it is to actually go down the whole pathway of coming up with alternatives. And in a place like rural West Virginia, the alternatives are few and far between. I think that's number one. Number two is the opposite effect, which is I'll take a hard stance. I'm writing no prescription drugs under any circumstances that are pain controllers. And then there are those patients who really have true, legitimate chronic pain who don't get treatment. When this epidemic started very early on, I had a patient who is a coal miner, a deep miner, and he came in one day, and I know him well, and he said, look, so here's the deal. He has a legitimate diagnosis documented with one of those expensive MRIs, had been to a neurosurgeon, inoperable, nothing else had worked. He'd been to a pain clinic in one of the nearby cities because he had the ability to get there. And ultimately, this guy was recommended that he take Lortab, a prescription pain medication. And he said, either you write the Lortab and I'll keep working as a coal miner, making one of the rare people in rural West Virginia 6 figures doing that, or you can cut me off and I'll go on disability. You pick, doc. So those are the kinds of conversations that happen in the exam room on a pretty regular basis. So to this program, here's what we did as a solution. Let me go back to the page that shows our locations. So that might look like it's not too far away, but these are real rural, real country roads that people are driving through. And so in the center of that green geographic area, we have hired an anesthetist who is a pain specialist. He has no real interest in doing family medicine, but does have a special interest in addictions medicine and in outpatient pain medicine. So hiring a patient that has such an expensive salary and also has such a high demand in a place like a hospital was a tough thing to do. But we were able to recruit him, and now every one of our patients who has chronic pain has to send their patient to this physician first for sort of a once-over. He does the workup, he looks to see if the patient is amenable to any kind of alternatives, and then sends those patients back to us as primary care doctors. But when you mentioned the importance of how do we get doctors to comply with PDMPs, well, I guess if you're the medical director, you can make them. And so one of the things we've said is every patient has to have a pain contract. That contract is as long as the contracts that you see in other places. One of the issues was making them readable for a lot of our patients, but it essentially says, we will do urine drug screens when we see appropriate. You will have one every time you come into the office to check to see if you're compliant with your medications. You'll bring in your pill bottles, we'll count your pills, we'll look at the PDMP on a routine basis, and at any point if we need your attention and we need you to be in the office, you'll be there. The patients who need chronic pain treatment and need the pills show up and say, this is in no way, shape, or form a burden. We need this medication, and we will toe the line because we understand the importance of doing so, because we understand that this is an epidemic that's affecting our communities. So what we have now is, of all of our patients who've been sent through the program, 30% of those people have stayed on prescription drugs. They've stayed on their narcotics that they had been on, and they've been sent back to their primary care doctor. They're living their life through their contract, through their urine drug screens, through pill counts, et cetera. 30% of those patients have been recommended or enrolled in a rehab program for an addiction. Those patients have either been successful or not, but 30% have been sent. 20% were taken off of their medications because they were able to have treatment that was something that was not a prescription drug. They were either to be on something that was ibuprofen, exercise, physical therapy, injections, et cetera. And 20% failed to maintain their contract and either had what we call a dirty urine or otherwise didn't show up for their appointments. So we think it's been a big success. It's something that has made it that right now family doctors who are finishing their training call me and say, hi, I'm interested in working for you. And I say, let's cut to the chase. Is it because you don't have to write pain pills? And they say, yep. I really want to treat diabetes. I want to treat hypertension. I want to see kids. I want to do well baby checkups. I don't want to deal with chronic pain. And so I'd rather drive 40 minutes from a place where a lot of people in West Virginia would choose to live, and I'll get in my car and drive so that I can avoid this problem. So thank you. I just wanted to give you a perspective of how real all of this work is.
Thanks very much, Sarah. That is a striking series of portraits, and it really, I think, sets up the discussion about how we go about helping you and your colleagues and the patients you serve, as well as trying to deal with this major problem that afflicts West Virginia and so many other states. Mark and I have some questions, and I would invite you to throw them at anyone you would like. If any of the panelists have comments that they would like to make based on what they've heard from their fellow panelists, I'd welcome those as well. You can take part in this by asking a question at a microphone, by filling out a green question card. And Mark, do you want to start? Or,
Sure, can I borrow your mic?
Oh, what a unique idea.
I have a question for Alan and really the doctor and anybody else. It seems that doctors are either overwhelmed by this problem or they think they can kind of eyeball their way out of it without using IT, without checking with the prescription drug monitoring programs or so forth. It kind of reminds me of when President Bush said that thing, I looked into Vladimir Putin's soul, but you can't really see that much. So what's the solution there? How do you get providers more engaged in using real-time IT?
Well, I give a couple of sort of infrastructure things. Get it into the electronic health record, I think, is the holy grail. If it just automatically pops up in front of you every time you see a patient, that's important. Proactive alerts are a shorter term, easier way to do that. Making it accessible through the health information exchange. Making it delegate access so that somebody who does the pre-treatment screen can pull that information, just print it out and put it on the chart so that it doesn't take, a few 30 seconds or a minute out of a very short consult. The other thing that I'll just say that I think is relevant here is there have been a couple of good studies saying that when the PDMP data was presented to the doctor, did they know? And in most cases, they didn't. In these studies, they were surprised to know how many other physicians their patient was seeing. And that information changed their prescribing, and it changed it in two ways. Sometimes they didn't write the script, but sometimes they found out that their patient wasn't being seen, who they thought was drug seeking, wasn't being seen somewhere, and they felt more comfortable prescribing. So I think that's good to know.
I'll just add a couple of things to that. One is, Alan had mentioned the importance of universal utilization and the increase in doctors using in a state like New York. Once it became universally utilized, that's critical. Some of the other innovations that he spoke about, obviously providers have a time-delimited amount of time to see individual patients. Integrating all of these fixes will not necessarily extend the amount of time, but actually make it easier for the healthcare team to do their job in an efficient manner in that same, 10 to 15-minute block.
I'll add one other comment, which is I think the idea of sending those lists proactively is a great idea. hydrocodone this month moves from being a Schedule 3 to a Schedule 2 drug. We went and printed the list last week of every one of our providers' list of hydrocodone prescriptions, presented those providers with those lists and said, this will now turn into one of those prescriptions that will need to be referred to our anesthetist. 8 out of 10 people were very surprised at the amount of hydrocodone they had written in the last 3 months. So I do think that just that sort of innocent awareness piece is key.
Following up on that, I wonder if some of our panelists could address some of the problems that we have been experiencing with with electronic health records, with physicians being frustrated at the time they have to spend tending those, with the difficulty of accessing the records themselves. And one final aspect of this that I came across in reviewing some of the materials that were put together is that the National Governors Association study that's reprinted in your packets points, or at least concludes, that the PDMPs are useful but underused. And I wonder if folks could comment on those related aspects.
I think one of the key elements is practice redesign. There's a whole push towards the patient-centered medical home model. The NCQA does certification to create medical homes and communities, and it's a totally involved discussion. But in short, there's a big emphasis on care teams, so that if a patient comes in, it's not just that they get worked up by a nurse with a blood pressure and a chief complaint, but instead that there's a whole team of people seeing that patient. As far as using this, I think you're right that it's hard for the physicians to navigate not only electronic health records, but these additional databases. We have our nursing staff pull all of that information for the providers ahead of time. So why ask the docs to try to go through and navigate that, but instead just have the nurse present them with, okay, you're about to see this next patient. Here's the deal. Here's what their PDMP says. Here are the last 5 scripts. I've highlighted anything that looks abnormal or a red flag, or hey, we looked at all that, nothing came up as a red flag, go ahead and proceed as planned. I think that's the key, is not asking them to spend the time to do it. I go back again to Medicaid expansion, and it really has changed the demand for healthcare services in our communities. It's great. We're thrilled to death that we have an increased demand for people who are not seeking care before because of being uninsured, but it just makes that time piece even more important.
Go ahead.
I completely agree with Sarah. I mean, I emphasized EHRs and I talked about health information exchanges, but if a PDMP sends data to the HIE, it still requires the hospital, the care system, to build their end, and they have a lot of things on their to-do list right now. So I do think, as Sarah said, optimizing these low-tech things that we can do immediately is really important.
Grant?
Yeah, CDC is involved in a couple of projects. Alan had mentioned the Office of the National Coordinator. We're working with SAMHSA as well to evaluate PDMP EHR integration, because we see sort of long-term that's really a holy grail for us in getting better utilization. As several of us have talked about, PDMPs really vary widely in their legislative scope as well as in their funding. So some states are only funded at several $100,000 versus other states, literally tens of millions of dollars go into PDMP utilization, or the running of the state prescription drug monitoring program. That has really big implications for the utility of that data and the availability of that data at the point of care. And so the last point I wanted to make is the power of the single sign-on and the delegated access, because Sarah had mentioned in West Virginia that's possible, but in many states that's not possible. So that really does limit the clinician in that short window of time that they have to see each patient.
And how about the issue I think Alan raised of states being able to communicate with other states' PDMPs? Is that a widespread phenomenon, or is that, can West Virginia tap into Pennsylvania?
We have an issue in any of our border communities. One of the things that I do a day a week is serve as the medical director for our state's health plan. And so another angle that I see from this is them coming up with those lock-in programs and asking about those patients. A lot of time what we find is that the patients who are on those border communities will flag after a patient has been doctor shopping across the border. So my answer is we don't do it well in West Virginia. We don't have a solution for it, but are aware of the fact that the HIEs that are statewide are great, but boy, it's going to be that real national database that's going to make the difference.
I would just add there's a lot of momentum towards interstate data sharing. The sort of contribution to burden of disease probably varies. If you're a big state like California or Texas, you may be less concerned about what lies across the border. If you're a small state with 5 contiguous bordering states, it may be a bigger part of the problem. And one of the things that's important to recognize is that the barrier to data sharing is not just technical and not even primarily, technical. It's on legal templates and, one state the nurse can access the data and the adjoining state the nurse can't access the data, then you have to have a complex legal arrangement to get them to exchange data. So that's a big barrier.
Yeah, I would say that technological possibilities are there. PIMIX and PDMP interconnect are 2 hubs that allow data sharing in a fairly robust way. But as Alan mentioned, it really is the legislative challenges, HIPAA variation across states that are really sort of driving the barrier for interstate operability of PDMPs.
Grant, is there a piece of the program you were describing, the CDC grant program, that would encourage states to move toward cooperation?
Part of the Prevention Boost program is, in fact, to maximize PDMP utilization. And so things like better leveraging state interoperability is critically important. But sending, as Sarah had mentioned, sort of proactive reports is another great example. Many states restrict who can access the PDMP, and some states, even state health departments, can't use it to sort of public health end. And obviously, we at CDC are very interested in using those data to inform practice at the population health level. So.
Okay. We have some folks at the microphone. Would you identify yourself and your affiliation, if you
Sure. My name is Becky Vaughn. I'm Vice President for Addiction Services at the National Council for Behavioral Health. We work with and represent publicly funded prevention and treatment providers all over the country, and obviously they're being overrun with this issue. But I'm particularly fascinated with this West Virginia model. I don't know what the population is in your center, but is this one addiction doctor specialist enough for your size population? And is there anything particularly special about West Virginia that would keep this from becoming sort of a replicable model for other rural areas that are struggling with all the things you talked about?
So to answer your question, we started out with 1 anesthetist. We now have 4 mid-level providers working with him, 3 nurse practitioners and a physician's assistant. We have a waiting list of 397 patients. I checked the day before we came to Washington. That was on Friday afternoon. And they are working as quickly as they can. We are using one of those in the capacity of only doing behavioral health services with those patients. And the real issue is it's absolutely something that could be replicated. It's finding the anesthetists who would want to do that work. Yeah. I mean, a lot of those people who go into anesthesia want to serve that role in its traditional capacity or want to work in a day center or somewhere that they can do more procedure-based medicine with fluoroscopy and other, interventions. Mm-hmm. So this is very grassroots, and I think the issue is it takes a special person who wants to be in a rural community in this capacity. But that really is the only barrier. I mean, if we could get that workforce built up, I think it's highly replicable.
Are you utilizing community-based providers, or are there even any community-based providers you can utilize in that area?
For mental health or for additional pain services?
Mostly for mental health and addiction.
So we're in the midst of that now. We're working with our behavioral health specialists at the state level through SAMHSA, and we're working on getting touch screens in the offices and, speaking about the electronic health record, an online piece through our patient portal that'll allow patients at home to answer a generic behavioral health survey that if the questions are flagged in and around addictions medicine or pain medication abuse, it sort of prompts them to another set of questions that then is just sent to us as their primary care providers. We then can integrate the behavioral health services through telehealth, and sort of on it goes. So the answer is yes, but boy, is there fertile ground for more
Right.
to do.
Thank you.
Hi, Whitney Englander with the Harm Reduction Coalition. Thank you so much to the panelists for a great briefing so far. And the problem of opioids is so complex. We could be in here for days discussing it and the various, comprehensive strategies. But noticeably missing from the conversation has been the role of naloxone in preventing fatality associated with overdose. What will it take to get some leadership around greater access and utilization of this medication, which has shown incredible efficacy in states like Massachusetts and other states that are able to saturate communities with naloxone and create a protective factor? Massachusetts saw a 50% reduction in overdose rates in counties with naloxone. So what will it take for some leadership to expand access through community-based programs and co-prescribing?
And I would ask whoever would like to take that on to spend a few seconds explaining exactly what we're talking about.
Sure. I'll start answering the question. Thank you for it. Naloxone is a overdose reversal drug. It's an opioid agonist that basically stops a overdose in progress almost instantaneously. It's very, very powerful. We at CDC are very committed, working along with colleagues at SAMHSA, of increasing naloxone utilization given its promise and potential, especially among police and fire and more basic EMS providers. So there's a real promise there. For us at CDC, we're also worried really from a primary prevention perspective. So how do we stop people from becoming addicted to opioids in the first place? So that's some of where our sensitivity exists. But we personally, me and I think CDC more broadly, we're very committed to increasing naloxone utilization and access.
Thank you.
Good morning. My name is Jeff Laredo. I'm from the National Institute on Drug Abuse at NIH. The first thing I want to do is endorse what Whitney just said. For those of you who don't know about naloxone, please read up on it. It's all of the federal agencies are really working hard to get that out more. I really just have I have a lot of thoughts, but won't hog the mic. Two things. Coming from a research agency at the NIH, we haven't really talked about research here today, so I just wanted to give a plug for the work that we and our colleagues are doing, drugabuse.gov, if you want to learn more about that. And the second is one of the things that you've highlighted today, both intentionally and not, is the dramatic need for drug abuse and addiction treatment in this country and the relative lack of access that not many, but most people who need it don't have right now. And Dr. Chouinard, I was getting increasingly frustrated, not because what any of the rest of you were saying was wrong or bad, but until you started talking about the real need for treatment as a primary necessary focus of what all of you and all of us are trying to do, it's really dramatic, and I didn't want that to get lost from the discussion. Thanks.
Comments? You're going to let it stand? Okay. Yes, go right ahead.
Hi, Mike Miller. I'm a health policy physician, consultant, and blogger. I've been working on this issue on and off for a number of years, and one of the challenges, I think, is it's often characterized, I know even in the IOM report, as an issue related to chronic pain. But it's kind of like chasing down the horses after they've left the barn, because no patient starts with a diagnosis of chronic pain or disease of chronic pain. They start with acute pain that becomes chronic. And one of the challenges, I think, is, as Dr. Chouinard said, is it's a lot easier to write a prescription than to deal with something more complicated. And I wondered if she could talk about, and I know it's not primarily a primary care issue, it's more around proceduralists and ER situations, but how we could go about addressing the issue of how acute pain is dealt with prescriptions and other modalities as a way to reduce the number of people who end up having chronic pain.
I think one of the problems is I don't see the demand for pain medication for acute pain too much. I guess it's very similar to overprescribing antibiotics. It's expectations. So I practiced medicine in California for a while. A mother would bring in her child and say, please, under any circumstance, do not give my precious baby an antibiotic because, I don't want poison in his or her little bloodstream. In West Virginia, they're like, give this kid an antibiotic and let's get done with this, right? So it is cultural, I think, is the point. And if you look at antibiotic prescribing rates, they're very, very high in West Virginia compared to in California. The same is true of prescriptions being written for pain medications and drug overdose deaths. We are, number 2 or 3? I think he said Alabama was number 1, Grant did, but we're on the top 5 list. So I think that with acute pain, people come in and they say things like this. A woman just Thursday, broken coccyx, fell, slipped on a step. Boy, does that hurt. And she said, can I have some of those hydros, quote. Sure, what are those? And so there's no consideration of maybe Tylenol would work, maybe ibuprofen would work, maybe sitting on a donut, those spongy things you can sit on to relieve the pressure, maybe that would work. It is an automatic expectation that a narcotic pain medication is the solution for any pain. And then what happens is it's this quick, addictive potential of these medications that people are treated acutely, and then they truly have a psychiatric component to the addiction. It's less about pain and more about addiction. So I think the answer is allowing the pendulum swung. Remember that about 10 years ago, there were doctors wandering around with buttons that said no pain with a red circle and a line through it because we were accused of undertreating pain. Now the pendulum has swung way in the opposite direction. They used to say, hey, you'll get sued if you don't write pain medicine for these people. They will sue you, they. And now it's, gosh, don't write anything or you'll be a pill mill. And so I think the real answer is just getting back to the midline and allowing the word to be out that you don't have to use a narcotic for every bump.
Yeah, no, thank you. The coccyx fracture is a great example. I just know of a few clinicians where after minor procedures, they've written for 60, 90, 100
right.
Opioids where the patient should be on maybe an opioid for 2, 3, 4 days.
Right.
Where's the rest of those pills going to go?
Right. I think that's the key.
Yeah, you
I
raised some
think-
good.
I think we would be amiss if we didn't say that having that number of controlled substances in your house, that we really need to secure them for the youth. Because that's where a lot of these cases, I was at, the Fed Up rally yesterday, where you see so many of the children, across the country being impacted by this disease. And so I think, we really need to make sure that we're locking those up as well. And you've probably seen that in West Virginia.
Yeah, one thing that that I didn't mention that's part of our requirements, this is just in our clinic, this has nothing to do with legislation, state law, nothing, is that patients have to come back every month for their pain medications. You legally can write more drug. I legally only have to check the PDMP once a year. Where the law is and what we require, and we simply say that if it's that important, you'll be there. And so making patients show up and only giving 30 days worth of the prescription, we think is a huge piece of this, because people throwing rocks through picture windows in houses to break into medicine cabinets is not exciting news anymore. It's common, it happens. Little old ladies' houses are broken into on a regular basis because people are assuming, hey, she looks like she has arthritis. I bet there's something good in her medicine cabinet. So if there's less there, and if the word on the street is that there is only a 30-day supply in any household, maybe it's less enticing.
I was just going
Yes,
to make a point
Grant?
about your comment about dose and duration really resonated with me, sort of amplifying Sarah's point. As dose goes up, the risk goes up quite dramatically. But I think there's also a tension here with cost. So alternate forms of therapy, cognitive behavioral therapy, physical therapy are costly. Alan mentioned in his remarks the issue around methadone, 2% of prescriptions, 30% of deaths. It's also 1/18 the cost of the next cheapest opioid. So the reason it's listed as the preferred drug of choice on many drug formulas is because from that tension between sort of cost containment it's pretty cheap. So there's some realities there that we as a country need to wrestle with as well.
Very good. Yes, go right ahead.
Avenel Joseph, Senator Markey's office. Dr. Chenard, I was very interested in the contract process that you guys have in West Virginia, and was interested in hearing a little bit more about the 30% that you said were referred to treatment, and what their success rates have been, and if you can talk about some of the limitations for treatment in those rural areas aside from just the recruitment and retention piece.
Well, in short, we don't do enough, and it's not successful enough, and there aren't enough beds, and there aren't enough bodies to treat them. That's really the skinny on that answer. But the part of what's been a success too is the personality of this anesthetist we have. He's very bristly, and people either love him or hate him because he says things like, you might have pain, but we're going to talk about after we talk about your addiction. And that can be kind of uncomfortable for people. So he refers them to outpatient and inpatient programs, but understand that like many other states, we are no exception. All of the beds are full. To get there is impossible. It's a call, and if we happen to have a bed available when you show up, we'll give it to you, but it might be taken on your way here. So I think a comment was made earlier about where the focus should be, and the focus should be expanding outpatient services and expanding inpatient services so that the people who actually do want help have it. We have lost a lot of people who were ready for treatment, who we didn't have a treatment plan available, who then went back to using. So I think that I would love to tell you that we had some success story, but we certainly don't.
Sarah, there's a card with a question that's quite closely related, but it's interested in one of the 20% categories, that is those who don't comply or don't pass their drug test. And you have sort of addressed it, I think, in your response just now. What kind of alternatives are there for those people? Is there any kind of follow-up that you can try to steer them toward so that they don't fall through the cracks? Telemedicine, almost anything?
No is the short answer. We don't have enough available to us. When you talk about the 20% that failed, those are people who either came in who also had street drugs in their drug screens, who had no drugs in their drug screens because they're diverting the medication instead. I mean, any scenario you can think of, we've seen it. That 20%, it's a pretty hard stop, where we've made it clear from the beginning the contract could not be clearer about what it takes. And if you follow the contract, you will be allowed to have any appropriate medication that you would need. So with that 20%, most of the time what happens is they come back to us as primary care providers, and we write them a taper of their medication simply so that they don't withdraw from those medications. But then as far as actually getting treatment for their pain, it's probably high and dry. I mean, we're happy to see them and offer them non-narcotic alternatives, but it's not like in the clinic that I showed you, I'm doing injections of paraspinal muscles, So it's not great.
Okay. Yes, go right ahead.
Melanie Nathanson, and I am a partner in a healthcare and income security firm in town. And thank you all. This has been incredibly illuminating and really interesting to hear such consensus among one of Ed's panels. Normally there's not. So
We're going to get downgraded on our evaluation for that very consensus.
it's good. It's very telling. But I'm curious, both Joellen and Alan noted the importance of PRR programs, particularly on the Medicaid side and in the private pay side. And Dr. Chenard, I'm curious, I don't know if West Virginia has a PRR program in its Medicaid and how you interact with that lock-in program. Sorry, Alan. But I also noted that almost all of you talked about the potential to have similar programs in Medicare, and would love to hear about how that might work and what those programs would look like and the potential benefits to expand into that program as well. Thanks.
So I hope this is just brutally honest. If we have a program in Medicaid, I don't know about it. So we might, but I certainly don't know about it as a practicing clinician. I'll say this. Our state payer, our state health insurer who covers all, school teachers and bus drivers and state road workers, et cetera, where I'm the medical director, it is a program that we do internally. There is nothing required about it. So we run those audits, and then we contact physicians and sort of say, hey, did you know, really as a courtesy and in hopes that we have to, we can cut down on the number of those drugs that we have to cover as the plan. So Medicaid does those audits as well, only because a good friend and colleague serves as their medical director, and we talk about those programs. But if it's a state requirement, I don't know about it, which I guess the point is, if it is a state requirement, it's not effectively getting to the rural health community.
Alan?
So I just checked, West Virginia does have a PRR, but I think that makes the point that I would make, which is this is an optimization problem.
Right.
The programs are on the books in most states, but the number of eligible people who are actually enrolled is probably pretty small, and we don't know how to say to a state, these are best practices, or these are the things that are really going to have an impact. So we have some work to do there. It's also not the only legitimate way that a Medicaid department might want to tackle this. They could do some other kind of case management thing, but it is a tool that we could optimize. Right now, we can't optimize it in Medicare Part D to the question because the authorizing legislation as it's interpreted doesn't allow lock-ins in Part D. So we need to allow them. And then we need to think about what are the elements of an effective program. Do we just enable them, or should there be some safeguards? Should there be a mandatory appeals process? Should the person who's being referred have some input into which doctor and which pharmacy they go to? How long should they last? Those are all things that may or may not need to be in the legislation, but we certainly have to give that tool to the plans.
So the PRR that we manage today is very successful. We do it not only for the commercial side, the health plans, but we also do it for TRICARE. And so TRICARE at any one time has over 1,000 locked in to a 111 program, which is what they call their restriction program. And so we have seen success. On the commercial side, we're seeing on average $100 per member per month saving. And again, a lot of it is generic drugs. But we are seeing considerable savings in not only costs, but trying to get assistance for these members.
Sure. Martin?
Yeah, I just have a follow-up question on that. One thing we haven't talked a lot about is the role of the plans and the PBMs, and that's our industry. The best data, we have it. And the PDMPs not only don't talk to each other and are delayed in how they're updated, but there's not easy access from plans, and that's not coordinated. And so it's kind of, we talk about all these policy regulatory solutions, which are important, but we have all this real-time data that's kind of left on the side. I don't know if you have any comments on that.
Right. So again, it's really up to the payers to decide what they want to do with the restriction program. Some of them are more aggressive than others. Some of them are kind of skittish, or they don't have the resources to be able to manage the case management on their end. Again, it comes back to resources. But I think they're all very concerned, and they're wanting those tools to be able to manage this. And I think Medicare is going to be key. I have stood at the MEDIC meetings quarterly for the last 6 years in the Medicare space, and the plans are struggling with not knowing what to do with members that are drug seeking and not having the tools to handle that. So we really need something in the Medicare space.
Yes, go ahead, Grant.
Yeah, I was just going to make the point that one step above patient review and restriction programs, some private insurers and managed care organizations like Group Health in Washington State have been at the forefront of both containing costs and improving patient safety by running what they call a coordinated care program, which is involves many of the things that sort of Sarah has highlighted, whether it be drug screens, step therapies, drug reviews. It's a much more comprehensive, holistic approach to managing an individual's care. It has huge cost gains or cost savings to the managed care organizations, but improves patient safety on the whole as well. There's some real potency there.
I would assume that Group Health has a bunch of Medicare beneficiaries. What do they apply these initiatives to that population?
I'm not sure. I don't have the answer to that, but I can research that.
One final aspect of this before we let it go, and that is someone has asked what programs, what states, what providers do around the country with the, what is it, 9 or 10 million dual eligibles, where Medicaid may have a restriction, whether you know about it or not, but you also have Medicare eligibility. Can you put your Medicaid beneficiaries who are also Medicare beneficiaries in that program?
Well, I'd defer to anyone else if they want to correct me, but if the dual is getting their drugs through Part D, then I would assume that they can't be in a lock-in program. There's an added challenge with that population, which is unlike most people in Part D, they can change plans quite frequently. So if one plan said, we're going to restrict you to a provider or a pharmacy, and the person was really set on avoiding that, they could switch plans, and so that's something that we'll have to think about.
Okay. There's a policy opportunity there for those of you who are out. Yes.
Good morning. Andrew Kessler on behalf of the ICNRC, the International Substance Abuse Counselors. Joe Ellen, you mentioned in an answer to a question before about prevention aimed at youth in terms of limiting the number of pills prescribed, so on and so forth, which prompts me to ask a question about another special population, which is on the other end of the spectrum, those over the age of 50 or even over the age of 65, who represent only 13% of the population, but are written about a third of all prescriptions. And if you look at the numbers, the one demographic that is outpacing all others in terms of opioid abuse are those over the age of 50. Yet here we are in Washington, where most programs that look at prevention, especially community-based prevention, are aimed at youth, which none of us object to, yet it tends to ignore those who are at risk for many complications when it comes to opioid abuse, such as broken hips, other broken bones, and other problems that come along with opioid abuse and lead to other health problems. Can any of you on the panel address any programs or ideas that you've seen for substance abuse prevention for those who are perhaps over the age of 50 or over 65, because that's where we see the numbers bearing out a very serious problem in terms of increase of abuse?
I don't know of any programs that are aimed at specifically the elderly or geriatric population. All I can say is that the program that we have in place is all comers. I think that part of the issue there is some assumption that, grandma is not going to really be a drug addict. And so whether it's, intentional or not, the problem there too is that, a lot of comorbidities in the elderly, cancer diagnoses, severe osteoarthritis, there are guidelines that state that opioids are appropriate treatment. So I think what happens is it's a slippery slope issue. In West Virginia, of the programs that I know about, there are none that are targeted to that population, but also not targeted specifically at youth. I mean, most of these are just looking at the topic age aside.
I think that's some of the real power of the interventions we've talked about this morning, whether it's PDMPs, PRRs. We haven't really talked much about clinical guidelines and how they can be better utilized. The real potency of those interventions is they are sort of one-stop shops, if you will. They are equal opportunity in helping people.
And as Mark talked about the amount of data that the PBMs have, this is where we can reach out to the physicians, because I will tell you in many of these cases that we work, the physicians are not aware, number one, that their patient that they have a pain management contract with is going to multiple physicians, and then they can address the situation with their member. But it doesn't matter what age they are, the situation happens. And so this is the front line for us to be able to address with the physicians and reach out to them so that they can take care of their patients. There's no need for them to go to, like in the examples of 17 different physicians to get controlled substances. And we have seen valid reasons, when we go back and look at the diagnosis with the medical claims, there are valid reasons for patients to go to a few, right? Because they have a long-term illness, and so they need multiples. But it has to be a comprehensive approach in the data. You can't just run data and then label them as a drug seeker, because that isn't valid. We really have to look at the comprehensive approach, looking at the medical claims, speaking with a physician, speaking with a pharmacist, to be able to get those patients help.
I want to add just one word about the Medicare population. We think about this as a problem in terms of overdose, falls. The risk of falls in this population goes way up if they're on these drugs.
And I will say that this idea of opening up lock-in programs to Part D Medicare recipients, I think it's a great idea. The awareness that we would have so that physicians understand there's doctor shopping, but it's just like in medical school, they say before you order a lab test or an x-ray, think long and hard if you want to know those test results, right? There is that sort of chasing things down and then ordering tests ad infinitum and never really knowing what you were looking for in the first place. With this, what I would caution is, and then what? Speaking to the need for more substance abuse, chronic pain treatment, et cetera. So now we have this lock-in, and I say, aha, so Mrs. Smith, you've been doctor shopping, right? And now what? Now what? Now what am I going to do, right? Now Mrs. Smith, who is addicted, who is on chronic narcotics, who doesn't have, I am in a better situation than most people because I've got this one employee. We say, does he have any idea how powerful he is from a contract standpoint? If he goes away, our entire program implodes, right? And we don't have people lined up for his job. And so with that being said, I think that what we really have to think about from a legislative standpoint is if we're going to be pushing these lock-in programs, they should really happen simultaneously with an improved ability to get patients help who fail once they've been locked in.
Yes.
Thank you. John Graham from the National Center for Policy Analysis. And as I've been standing here, I realize my question is one that maybe invite too much risk for anyone to answer, so I hope someone will answer it. But Dr. Baldwin mentioned a positive correlation between heroin abuse and opioid abuse, and you mentioned breaking into old ladies' houses. So I'm wondering if all the solutions we've discussed are in the healthcare system. Does anyone have anything to say about sentencing guidelines or parole guidelines or anything police and judges can do that would help you all do your jobs better and move everything in the same direction?
Well, I will speak on behalf of my investigation unit. We work a lot of physician cases, we work a lot of pharmacy cases, and we're not seeing strict enough penalties for those pharmacies and physicians that are committing fraud. So I would say, yes, we definitely need stricter sentencing guidelines because a lot of these guys are just getting a slap on the hand and then they're moving on and opening up another one, or a family member's opening up another one, and they start again. So I would definitely encourage that.
If I could just jump in too, I think what Dr. Chenard said is really important. So you find out the person's an addict or whatever, and what do you do about it? That to me highlights the role that the pharmacist can play, because if they're plugged into this, and if there are pharmacy homes, they're lock-in, whatever you want to call it, they can simply deny the script. They can just simply not give it out, and without any further explanation. And I often think that the prescribers are the ones who know the most, but the reality is the supply, the chokehold is right there at the drugstore counter. And the role that drugstores and pharmacists have, I think, is very large in actually preventing the transfer, obviously, from the drug to the patient. They ought to really play a big role in this. And I think it is very hard. If you're the doctor and you don't have another solution, the person's hurting, or say they are, that you don't have another solution, you're not sure if you could give this, then what do you do? So we haven't talked much about the role of the drugstore, but I think they have an important role too.
One thing to add is just there is some reporting and evidence that some people who get addicted to prescription opioids will transition to heroin. Evidence is, though, that the risk period, the latency is very long, which means if we do the things we're talking about, we can intervene before that transition happens.
We have just a few minutes left. I guess we'll try to accommodate the three of you who are standing to ask your questions, but I would ask that you be as brief as you can, and I'd ask the panelists to be as brief as they can in their responses. Go ahead.
Thank you. Hi, my name is Rachel Gandel. I'm from the American Congress of Obstetricians and Gynecologists. There are a lot of things that we're interested in with this issue in particular, but I'm hoping that you can speak to how you find a balance or rectify the programs that you've talked about this morning with the growing popularity of patient satisfaction surveys and things like that, and a lot of insurers and plans relying on those and either dinging doctors financially if their surveys are low, or other kind of issues and physicians are penalized in other ways for those lower scores.
So if you don't give me the opioid, I'll downgrade your rating on the NCQA form.
Actually, it was, I don't know if it's true, but there was a rumor in one of our communities, in our most southern clinic, that health grades was a way that patients communicated about opioid prescribers. So that if someone got a 5, they gave out opioids. If someone got a 1, they did not give out opioids, and this is a way to sort of talk to each other about that. So as a physician, you're hoping to get a 1 so that you don't have people knocking on the door. So I don't know what you do about that from the health plan perspective, other than hope that people realize that that sort of funny business goes on.
Anybody else?
I would just mention a couple of things that, being from OBGYN, there's a cascade of other negative health outcomes, including an increase in neonatal abstinence syndrome of babies being born addicted to opioids. It's really tragic. Hep C, some drug driving, which was hinted at earlier. So it's not just the, being addicted to a prescription opioid, but there's a cascade of other issues that are problematic as well.
Yes, ma'am.
Hi, Avenel Joseph with Senator Markey's office again. So we spent a lot of time talking about prevention at this forum, and specifically talking about the PDMPs. And a lot of what was talked about was the need for interoperability, for sort of standard regulations in terms of what providers have access to the PDMPs in the state. Because of those variables, a lot have argued that perhaps there's a need for a federal PDMP. And that was one of the things that you guys haven't discussed, and I was wondering if we can get some perspectives on whether you think that this is an entity that should be housed and operated by the state, or something that should be taken over by the feds.
Good question. Go ahead.
It's a really good question. I think a smart way to go about it wouldn't solve all the problems, wouldn't be to have the federal government run one big one, but to simply have uniform standards. And to create some way that payers can have better coordination with the PDMPs. Right now, each of them is just kind of on an island by themselves with semi-outdated data. I mean, from a drugstore shopper or doctor shopper's perspective, having even a 7-day delay is great for them. So if there are uniform standards, more regular updates, more access to payers, and again, payers, health plans and PBMs and so forth, literally, 200 million people plus active, updated, regular files on utilization that can be used, in a very productive way. But uniform standards would be, I think, a good way to get to what you're talking about.
And Mark, to your point, Alan had mentioned the Brandeis Center of Excellence on PDMPs. They have 35 best practices identified that a PDMP should have to be maximally utilized. I think that's a great resource. Because the practice of medicine is governed at the state level, I think that's really where we need to be focused, because I think it'll be a lot more challenge to infuse federal down across the states. So I think because of the way medicine is regulated, I think states is the sweet spot here.
All right. Got the last question coming up.
Nick Ulecki with the Ways and Means Committee. So in listening to what everyone said up there, it pretty much sounds like the more tools that we give to the plans, to all the providers, the more tools is better. And kind of that's the logical way of going. And so kind of from my perspective, and Ed, thank you very much for mentioning that there is a legislative idea pool here. But my perspective is kind of a couple of things I think in the crowd where there might be some inkling concerns in the back of people's minds. And obviously we've received tons of comments on what people's concerns are with potential lock-in programs or PRRs, and so if you could just address a couple of these, I think they're pretty quick. So, I think a lot of people are concerned over, what if grandma's locked in because she was, overprescribed for certain pain medications? Can she still go anywhere to get her allergy medications? Can she still get her diabetes medications? Is she gonna have a problem with access to those? And a lot of the concerns that we've gotten, and some from some physician groups, is don't tell the doctors what to do. The plans shouldn't be telling them. So if you could address the fact that plans do indeed have medical directors and people that are medically trained, as well as this kind of troubling concern that we received as well, that we don't have to do anything. CMS and what they're doing is working. So if you could address those, I'd appreciate it.
Go right ahead.
From the restriction programs, they are only restricted into controlled substances, so they can go to any other physician for non-controls. They can go to any pharmacy for non-controls. It's just related to their controlled substance utilization, and that is it. And so we want to make sure that they're getting the proper pain treatment from one physician, not 17.
And there have actually been a couple of analyses of PRRs that specifically looked at that question of did access to non-controlled substances change, and found that it did not.
And just to finish that up, one of the reasons, and I think Alan said this earlier, that the word lock-in is so bad is grandma, whoever, they choose their own pharmacy. Nobody's trying to limit the pharmacies. We just need to know which ones they're going to. I mean, everybody needs to know that in the system. And so they will be able to get other drugs anywhere they want, but for those controlled substances, it would be probably the pharmacy that she's already going to. And again, your point about trying to make doctors do more and so forth, I think is significant. I think gets back to probably the most automatic way to deal with it, although not complete, is at the pharmacy level. Pharmacies are already wired. They've electronically adjudicated for 25 years. They already have the technology, and if they can prevent the supply moving over and then have some way where providers are alerted and so forth, that's a good way to start the program that doesn't add any other burden to any of the already overburdened doctors and so forth.
Well, I apologize to all of you who wrote questions on cards. There are some terrific questions here that we're not going to be able to address today because we're simply out of time. But it is a topic that obviously has a number of different threads that we haven't been able to weave into a single solution yet, but we will come back to it as our ability to schedule something permits. I want to thank our colleagues at PCMA for enticing us into doing this program in the first place and helping us to organize it. Ask you to fill out the blue evaluation forms as we finish up here. But before you do that, or maybe you can do it at the same time, I'd be interested to see that. If you would join me in thanking the panel for a terrific, insightful conversation.